World Glaucoma Congress today, and I was asked to speak today about this question: neuroprotection and regeneration in glaucoma, are these possible? And brief financial disclosures, other than consulting fees from some of these companies, none of the others are really relevant to today's presentation. So I'm particularly focused on not the eye pressure portion of glaucoma, which we're all engaged in treating our glaucoma patients, but on the other side of the coin, which is the retinal ganglion cells and their axons that degenerate in glaucoma. And our fundamental problem in the irreversibility of vision loss is that there's no retinal ganglion cell regeneration after optic nerve injury. After injury to ganglion cell axons, for example, in the optic nerve head, there's a retrograde degeneration. There's no regrowth back to the brain, and a short time later, the retinal ganglion cell bodies die. And that short time later is critical because that space in between injury, let's say because the eye pressure is too high for that patient, and the metabolic pathophysiology that's now damaging ganglion cells and hurting our patient's vision, leads to actual axon damage. But then there is indeed this window before retinal ganglion cells die. And it's that window in between injury and death that we really want to intervene in and to promote survival, neuroprotection, and axon regeneration, regrowth of the axons down the optic nerve, and also, I think, of relevance, dendrite regeneration, regrowth of the dendrites into the retina to collect visual information. Now, as a field, we've learned a lot about glaucoma pathophysiology, and I'm not going to review these in depth, but these bring up many candidate factors that we can actually now start to move into clinical trials. These are factors like neurotrophic factors that could counteract apoptosis or cell death of retinal ganglion cells. Recent, very exciting data on dendrite retraction of retinal ganglion cells that leads to death, and synaptic dysfunction that leads to death, and that those might be countered by blocking C1q, for example, a complement protein, or providing insulin-based or IGF, insulin-like growth factor signaling. Axon regenerative failure, which is mediated by transcription factors like Kruppel-like factors, KLFs, or Rho kinases, which we now have Rho kinase inhibitor drugs to try. And all of these lead towards our ability finally to address unmet needs in glaucoma. And these are better treatments that go beyond our treatment with eye pressure lowering medication, neuroprotection to keep retinal ganglion cells alive and slow the disease that way, protect our vision. Regeneration, can we get the axons and dendrites to reconnect to their normal targets? And neuroenhancement, and that's a term that we've taken from the Alzheimer's literature, where we ask whether we could give retinal ganglion cells a booster shot and improve their function and thereby improve patients' vision acutely. Now, how do we move these advances out of the laboratory into the clinic? Well, the old thinking was that neuroprotection takes a long time to measure, and that on average, glaucoma, thankfully, in many of our patients is a slower disease. But if it takes years to show that a neuroprotective drug can bend the curve and protect people's vision, that's very difficult. That's a very unpalatable, very expensive clinical trial to propose. But the new emerging trial design points us in a much better direction, whereby we can protect and improve the function of sick but not yet dead retinal ganglion cells, and look at primary endpoints that could be measured in months or a year, year and a half in the case of neuroprotection trials. And to get there, we want to incorporate improved patient selection and trial design, including with new exploratory biomarkers, including our traditional markers like visual field functional testing. We have, using these approaches, a number of trials in various stages of progress. For example, testing nerve growth factor, which is just completed a phase 1b, phase 2a style randomized control trial. Anti-C1q, this complement protein that I mentioned before, a phase 1b randomized controlled trial was just completed. And in that trial, we saw great target engagement, bringing down the patient's levels of C1q in the eye. We're in the middle of a phase 2 randomized controlled trial of ciliary neurotrophic factor, again, one of these neurotrophic factors that can both prevent the death of retinal ganglion cells and promote their regeneration of their dendrites and their axons. And another trial that we're excited about getting started is using virtual reality goggle-based visual stimulation. So I'm not going to have time to go into all of the details of these trials, but I do want to point out 2 published trials that point us in the direction of the relevance of taking these candidates out of the lab and into the clinic. And that is that we have some real-world data on neuroprotection in glaucoma. So first, the United Kingdom Glaucoma Treatment Study, UKGTS, showed that eye pressure lowering with latanoprost, in addition to lowering the eye pressure, does indeed protect patients from visual field progression compared with placebo. Now, those data are not a surprise to any of us. That's why we're treating our patients with these medications and surgeries. But it gives us a path forward on the clinical trial design to show visual field protection, neuroprotection in these patients. Another good example of trial design involves the low tension glaucoma treatment study, or LOGIT study. In that study, brimonidine was directly compared to timolol as an eye pressure lowering, but instead of with eye pressure as the outcome, with visual field as the outcome, and showed that brimonidine conferred visual field protection compared with timolol. There are a number of reasons that doesn't quite nail down whether brimonidine is indeed neuroprotective in our patients. But again, it sets up the premise that we can take candidates out of the lab into the clinic. So what are some of these candidates that I'm excited about? Well, again, we're making great progress in the laboratory. And if we think about the retinal ganglion cell and what's going on there, and in fact, what's going on inside the retinal ganglion cell, we've learned a lot about how neurotrophic signaling collaborates with electrical activity conferred by visualization in people to promote survival and neurite outgrowth through stress and injury signaling when the retinal ganglion cells are under stress in glaucoma. And a number of these factors, including nerve growth factor and ciliary neurotrophic factor, as I mentioned before, are already entering clinical trials. Another really exciting area involves the Rho kinases, downstream of those neurotrophic factors on the way to regulating both survival and regeneration. An enzyme called Rho activates Rho kinases, which are also called ROCK. And there are now drugs that we're using clinically that are ROCK inhibitors, as everyone here knows, like in the United States, Ropressa is one such example. And we've demonstrated very clearly over the years, we and many other lab groups, that these ROCK inhibitors really do promote survival and regeneration. We recently published a study asking whether topical Rho kinase inhibitors using notarsadil can, in the rodent, promote survival and regeneration of retinal ganglion cells, and found indeed that it can. Each of these green dots is a retinal ganglion cell, a living retinal ganglion cell in the rat retina. And after optic nerve injury, most of those retinal ganglion cells die. But with topical therapy with notarsadil, we can save a large fraction of those retinal ganglion cells. And that's shown here spread across the center, the middle, and the peripheral retina. Furthermore, we found that it can strongly promote axon regeneration down the optic nerve. And I'm not showing it here for the interest of time, but we were able to show the molecular pathways that get activated as notarsadil is having that positive effect. That's shown very briefly here. So in conclusion, what we've learned is that neurotrophic factors, Rho kinase inhibition, and other strong candidates are ready for neuroprotection testing in glaucoma, that these therapeutic candidates can be studied in our glaucoma patients, and in particular, merging therapeutic testing with biomarker exploratory endpoints to cross-validate is going to give us particular power as we launch these trials. Our next steps are to move these top candidates into human clinical trials. And with that, I thank everybody very much. It's a pleasure to have been here and participated.